I'm going to talk about opioid and heroin addiction and what we're doing about it. And there are really three take-home messages here. One is that the problem is very, 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 very bad. It's very bad in the Upper Valley as it is elsewhere in the country, but it's particularly bad around here. And secondly, we don't know what to do about it. Third, as usual, people at APD are trying to partner with other people and organizations in the community to try to come up with some sort of a solution. So I'll tell you a little bit about what we started to do. How many people saw the New York Times article that Sumuni was talking about? Not too many. It's worth looking at. It talks about a drug called Suboxone, which is something that I provide. A few basic figures to start with. In 2011, which was the last year we really had really good statistics, 200 people died of opiate overdose in New Hampshire. 200 people died of opiate overdose, and of those 200 people, 160 of them died from prescription opioids. It is a terrible problem. In New Hampshire, if you look at the age group 18 to 25, over 12% of people 18 to 25 are abusing opioids, mostly prescription drugs. That is higher than any place else in the country, where the average is about 10%. And if you look at every age group in New Hampshire, we are higher in our opioid abuse than any place else in the country. You just heard Laurie talking about centering and our attempts to really have really healthy babies delivered. Well, now in some of the hospitals around the state, 25 to 30% of the babies are born to addicted mothers. And we have something called neonatal abstinence syndrome, where the babies are born addicted. And it may take 16 days on average for them to leave the hospital instead of the usual 2 to 3 days. We're not equipped to deal with neonatal abstinence syndrome in this hospital, though we see a number of women who come in who are addicted, and Laurie and her partners have to refer them up to the medical center to a high-risk pregnancy, at the high-risk pregnancy unit. I mean, this is a real tragedy, and so we're trying to do something about it. We could spend a lot of time talking about where they get the drugs, but that's really not, it's not that they're being prescribed them themselves. They're buying them on the street. They're stealing them. We had a bank robbery in Lebanon yesterday, and I look at that, and it's obvious to me this is somebody who's strung out on drugs, who's trying to get some money. They're really desperate. They do very stupid things. And what we found in our own practice was that there are a lot of people who are addicted to opioids. When we ask questions about it, we usually don't get honest answers to begin with, and then little by little, as people found out that I was prescribing Suboxone, I would have more and more people coming in and saying, I've had this problem, can you help me? So what is Suboxone? Suboxone is a drug that it is an opioid. It's an opioid analog, and it binds to the same receptors in the brain that drugs like Percocet and Oxycodone and OxyContin and heroin bind to, that give people pleasure and pain relief. It doesn't bind to the same receptors in the brain as strongly as those other drugs do, but once it's there, it prevents the other drugs from getting in there, and it also stays there much longer. So people don't get the same kind of high from it, and it prevents them really from taking other opioids at the same time. When the drug was first introduced a number of years ago, it was felt that this was going to be kind of a miracle drug, and that people wouldn't get addicted to it, and they wouldn't get high on it. A lot of those initial hopes have been dashed. We know that people are abusing Suboxone just like they're abusing a lot of other drugs. But what we do now is, what I started doing was I started working just with the patients in our practice, because we couldn't open it up to everybody. There are only 44 physicians in the state of New Hampshire who are licensed to prescribe Suboxone. I'm one of them, and where each one of us is allowed to prescribe for up to 100 patients. I only have about 15 patients at any one time, and I haven't wanted to expand it beyond that at this time, and I'll explain that in a second. Already, a quarter of the physicians who are prescribing Suboxone have been sanctioned by the state of New Hampshire by the board because they have been abusing that privilege. They are what we call script doctors. They're making sometimes, there are people making hundreds of thousands of dollars just prescribing this drug. The value on the street is enormous. People are buying it on the street, and at the same time this is going on, we're now having a huge problem with heroin. Why? Because the cost of the prescription drugs like Percocet and OxyContin sort of thing is so high that people, and so high that it's as much as $1.50 a milligram out on the street. So if you're taking a small amount, like 60 milligrams a day of oxycodone, if that's what you're buying on the street to feed your addiction, that's $75 a day right there. Well, there are people who are spending $500, $750 a day on that addiction, and they're prostituting themselves, they're stealing, they're dealing. That's the only way they can afford it. So a lot of them now are turning to heroin because heroin is so cheap and also very addictive. So we've had to do something. And so with the people in my practice, I've said, okay, if you have a primary care physician or nurse practitioner in the practice who is willing to take care of your primary care needs, I will prescribe Suboxone for you with a contract. And the contract says that you have to be in counseling with a licensed alcohol and drug counselor at Headrest or at West Central Mental Health Services. We've now expanded somewhat to Clara Martin over in Vermont. And you have to agree to have me communicate on a regular basis with your counselor. You have to agree to have random urine drug screens so we can see that you're not using other drugs and also that you are taking the drug that we think you're taking. And you basically have to come in to see me to get your medication on an interval that I determine with the licensed alcohol and drug counselor. So it's been an interesting journey working with these patients. I literally have had people come in and hug me and tell me that I've given them their lives back because the drug eliminates their cravings. They're able to think, they're able to work, they don't spend their day worrying about when they're going to get their next fix, whether or not they're going to get caught by the cops out on the street trying to buy some oxycodone or Suboxone or any of these drugs in the Walmart parking lot. They're able to hold down jobs. They're not stealing, dealing, prostituting. And it has been really remarkable. Now, that sounds like a wonderful story, but the reality of this is that of the people I've taken care of over about the past 6 years since I first became licensed to do this, I would say about a third of them are success stories. They're doing very, very well, and I've even had a couple who we've tapered off of Suboxone, and they're off all opiates completely. About a third of them have ended up falling out of the program, and some of them are in jail. They really aren't committed to their own recovery. And the other third are probably lying to me, and I don't know it. So I'm working really hard right now with these other agencies and with some colleagues up at DHMC and addiction services there. And in January, we're going to have a stakeholders meeting. And we're going to sit down and talk about how we as a group can figure out some sort of a plan for the community to help deal with this scourge. And we're going to try to figure out how to identify those people who really will do well, who we know will really do well, and really should spend our efforts on those folks. Who is not going to do well, and how to follow them, and how to get them connected with other services so that they can put their lives together and do better.
So thanks, Peter and Laurie and John. That very, very interesting. You can see really different aspects of medicine, but again, I think there's that common theme of really caring deeply about these individuals who are affected by their experiences with the healthcare system.